Thank you, everyone, for attending my talk today. My name is Anson Tharayanil. I'm a medical science liaison for Genomic Health's Medical Affairs Group, Urology. And today my talk will be focusing on utilizing MRI and genomic testing for the treatment selection in early stage prostate cancer. Now, as a quick overview of the epidemiology of prostate cancer, it's the most common non-cutaneous cancer diagnosed in men in the United States, with an average diagnosis volume of 174,000 new cases. This roughly translates into 1 in 9 men who are born today will be diagnosed with prostate cancer in their lifetime. Because of the sheer number of cases diagnosed, it's actually the second leading cause of cancer death in men in the U.S., and it's attributed to over 30,000 deaths per year. Now, the problem with prostate cancer, one of the main challenges with prostate cancer, is that it's actually considered an overdiagnosed disease. So while there are a large number of deaths that are attributed to prostate cancer, there's a much larger volume of patients who are diagnosed with the disease and treated for the disease, but they aren't necessarily dying from that disease. And so one of the primary challenges in modern day prostate cancer care is to really separate out the patients who need immediate therapy to cure them of an aggressive form of the prostate cancer, while identifying the majority of men who don't need aggressive cancer therapy because they won't have a disease that will affect our overall mortality. Now, we see this data bear out in a lot of trials that have been run to look at the natural history of prostate cancer. So if we look in the SPCG4 trial, this was a trial recruited that began enrollment in 1989 through 1999, and it was really in the era before PSA screening began to be put into clinical practice. In this particular trial, we had about 700 men who were divided into a watchful waiting group, which is simply observation of the cancer after diagnosis with no further intervention. And that was compared to a radical prostatectomy group where the patients, once they were diagnosed with prostate cancer, went for immediate surgery. Now, the one thing to note about this group of patients is that they had a much higher disease burden than what we would see in today's patient. These patients actually had palpable disease on digital rectal exam, and so they would typically be higher volume cancers as well as higher grade cancers. All that being said, these patients, especially in the watchful waiting group, roughly 71% of those patients were still alive at 15 years despite not receiving any sort of therapy. Conversely, despite having received immediate surgery, almost 20% of men died at year 15, and approximately 11% of men had benefited from actually receiving that surgery. So again, we can see that there's already patients in these early trials where they have a large burden of disease but can still live for more than a decade despite not having any sort of curative treatment. Now, after the SPCG4 trial had concluded, PSA screening had become more implemented into standard clinical care to find and detect prostate cancer earlier in the disease course. In the ERSPC trial, we see that 13,000 patients were studied, with half the patients going into a control group that did not receive PSA screening, while the intervention group did receive PSA screening. At 13 years median follow-up, we see that the control group the intervention group that had PSA screening had a 27% relative risk reduction in mortality. What this translates into in practical terms is that 98 men would need to be screened, 5 prostate cancers would need to be detected in order to prevent 1 prostate cancer death. Now, there was certainly a discernible benefit in doing this sort of large-scale screening. However, the authors themselves note that there were harms in doing this sort of screening. And particularly, they cited that there was an overdiagnosis and overtreatment of 45 cases and a loss of 1,100 life years free of prostate cancer per 1,000 cases. Essentially, they're saying that we're picking up clinically insignificant disease and giving a patient a cancer diagnosis, even though they wouldn't necessarily have been negatively affected by that prostate cancer within their lifetimes. So the authors go on to state that strategies are actually needed to reduce overdiagnosis before generalized screening should go into effect. We see in this table that there's a summary of multiple trials over the course of the last 30 to 40 years. As I mentioned earlier, SPCG4 trial was in the pre-PSA era. And what we could see is that in the watchful waiting or observation arm, where the patients didn't receive any sort of intervention after their initial diagnosis, that the rate of death at 15 years was roughly 30%. And the incidence of metastatic disease after that initial diagnosis was almost 40%. And for the patients that received surgery, the rate of death was almost 20%, and the rate of metastatic disease was 1 in 4, over 25%. However, you see over time from SPCG4 to the PIVOT trial, which is the start of the early PSA trial, all the way down to the PROTECT trial, which was our most recent data, we see that there is multiple trends happening. One is that because the prostate cancers were being caught earlier because of PSA screening, we see that the event rates for death and metastasis are declining across all cohorts. Also, we see that the delta between the outcomes in the observation group versus the surgical intervention group are actually shrinking. So going from 28% to 17% in SPCG4, in PIVOT trial, we see the delta shrink from that 11% delta to about 4%. And then in PROTECT trial, there's barely a recognizable difference between radical prostatectomy, radiation therapy, or active surveillance. However, the interesting thing is that in the PROTECT trial, where they actually looked at active surveillance as a modality compared to radical prostatectomy and radiotherapy, there was actually an increase in metastatic disease for the active surveillance cohort versus the immediate therapies of radical prostatectomy and radiation. So there is some work to be done here in order to continue to close that gap for metastatic disease incidence. And the one thing to note between all these trials is that watchful waiting and observation can roughly be considered the same sort of protocol, where the patient is diagnosed and then no further treatment is done except to manage any signs of progression, but no actual curative therapy is initiated. In active surveillance, however, the disease is intentionally monitored over time. So rather than doing an immediate surgery, these patients are actually followed routinely with biopsy or PSA and looking for moments of disease progression, at which point they can actually switch over and get a immediate therapy. And so because of PROTECT trial and because of the other trials that I had just discussed, the concept of active surveillance had really taken hold as a valid modality for managing early prostate cancer. And the point of the purpose of active surveillance or active monitoring is really to minimize the risk of overtreatment by avoiding immediate radical intervention. However, it's not necessarily writing off intervention as a whole. It's simply that we'll be monitoring the disease in regular intervals, be it 12 months, 18 months, or perhaps longer, and that we can initiate actual curative therapy when it's deemed necessary. So the whole point of active surveillance is to delay as opposed to dismiss curative therapy. And the benefit of doing this is that you can maintain a patient's quality of life for a longer duration while not negatively impacting their oncologic outcomes. So one of the goal really of modern prostate cancer therapy, particularly for early stage prostate cancer, is to minimize the probability that prostate cancer or its actual treatment will shorten a man's life expectancy or impact his quality of life, but also be mindful of the cost of the care and the treatment when selecting the optimal approach. All the different options that are available for early stage prostate cancer do come with potentially significant financial cost as well as physical side effects. When you look at active surveillance, at least the first year cost is approximately $900 a year, whereas a radical prostatectomy or the various forms of radiation therapy can go far beyond $20,000 to $30,000 per year. So ideally, when it comes to managing localized prostate cancer, we would like to treat only those cancers that have metastatic or lethal potential while putting everyone else on active surveillance so we can monitor their disease and then choose to treat them when there's some sort of clinical indication to do so. And based on all the data that we just saw, the national guidelines committees have decided to recommend active surveillance for a subset of early stage prostate cancer. Specifically, the AUA and NCCN guidelines have noted that patients who are considered very low risk or low risk in terms of prostate cancer risk of recurrence would benefit from active surveillance. So very low risk and low risk are typically patients with that are picked up on PSA screening. They have low-grade disease with a low PSA and also low tumor volume, as in the number of cores that are found to be positive with cancer are quite low relative to the number of cores taken. Now, while the guidelines were pretty favorable about using active surveillance in the very low and low risk groups, they were a little bit more tentative when it comes to patients with low volume but higher grade disease. So specifically, the AUA and NCCN guidelines said that clinicians can consider using active surveillance in select patients with favorable intermediate disease. Again, that would be low volume 3+4 disease, and we'll get into that a little bit more later. However, they didn't necessarily offer specific guidelines on how to select for those patients, so clinicians are left to figure that selection criteria for themselves. Different institutions have put out their own versions of active surveillance selection criteria. However, we can see from here that they vary quite widely depending on which institution you're at. The most conservative protocol that I found was from Johns Hopkins, which really looked at very low volume, low-grade disease with a very low PSA and only a single core positive, or excuse me, less than 2 cores positive. Whereas the Royal Marsden Center in the UK actually has much more permissive criteria where you can have T1 or T2 disease, have a PSA up to 15, and could have low-volume 3+4 disease. So this actually spans quite a range where Johns Hopkins only allows NCCN very low patients onto active surveillance, whereas Royal Marsden will actually allow very low, low, and some favorable intermediate patients onto active surveillance. So again, there is a wide range in terms of what people consider to be patients who are eligible for active surveillance. Now, because there's no real consensus on who to pick for the active surveillance protocol, it should be no surprise that we actually see a wide range of variability across providers. The data here we see from the Music Consortium out in Michigan. It's a collection of 43 different centers, both academic and community, who report out on their prostate cancer patients. In this particular chart, we see 13 different centers, all represented by the different vertical bars. The circles represent individual physicians within a particular practice, and the size of the circle indicates the volume of patients with NCCN low-risk disease that they might see. And the y-axis denotes the percent of those patients that are put on active surveillance. So if we look at the third bar, which is an independent clinical site, they have approximately 10 physicians who are practicing there. And what we can see is that 2 physicians who see roughly the same number of patients who clinically and pathologically look identical. They're all NCCN low risk, 3+3 disease with low PSA. Despite the same 2 physicians in the same site looking at basically identical patients, one of those physicians puts 60% of those patients on active surveillance, where the other physician puts roughly 20% of those patients on active surveillance. So again, a patient's treatment selection can vary very highly based on where they're going and which physician they happen to be seeing. We also see quite a bit of variability between countries. In active surveillance rates in Sweden for very low and low risk patients back in 2014 were as high as 91% for very low and 74% for low risk patients. This is actually quite high, especially compared to the United States, where only 40% of low-risk patients are receiving active surveillance, despite the fact that NCCN guidelines recommend all of those patients receive active surveillance as their initial form of treatment. If we were to actually get that 40% closer to the 74% like we see in Sweden, we would actually be able to add almost 20,000 patients to the active surveillance treatment selection, and where they can actually defer or delay that radical prostatectomy and substantially increase their quality of life. So all this data begs the question, what is preventing mass adoption of active surveillance in the United States? And the primary driver behind this is the lack of robust risk stratification tools at our disposal. So particularly the needle biopsy is how we diagnose prostate cancer. And because of the sheer nature of needle biopsies and the fact that they only sample less than 1% of the total prostate volume, we're left with wondering whether or not what we're seeing on the tumor, or excuse me, what we're seeing on the needle biopsy is really reflective of what's going on in the entire prostate gland. And there's also patient and physician reluctance. Again, there's this uncertainty about actual risk classification based on the diagnostic biopsy. There's also psychological factors like the anxiety about inaction in choosing active surveillance rather than doing something immediately because of the cancer diagnosis. There's also the time and effort required for prolonged surveillance. Oftentimes, patients have to come into the office multiple times a year, either for bi-yearly PSA checks or yearly repeat biopsies. And these repeat biopsies also come with their own side effects, in particular sepsis or infection. Now, before we go on in discussing the limits of the current tools available for prostate management, I wanted to talk about Gleason score grading. The Gleason scoring system was developed in 1966 by Dr. Donald Gleason and the BA research group, and it's really been a fantastic workhorse for the prostate cancer community in terms of really characterizing a patient's diagnosis and helping us understand how aggressive or indolent a patient's disease is. Originally, the scale was from 1 through 5. And very similar to breast cancer grading, the higher the number, the poorer the grade, and the worse outcome for the patient. However, because prostate cancer is a highly heterogeneous disease, unlike in breast cancer where you have a single grade, grade 1, grade 2, grade 3, the pathologist for a prostate cancer diagnosis has to actually list the 2 separate grades that are available that typically are seen when diagnosing a biopsy or a radical prostatectomy specimen. So there can often be a mix of patterns that can be seen on the tumor, and so you can have pattern 3, you can have pattern 4, and you can have pattern 5. So in terms of Gleason's scoring, what we see on the left-hand side is how these scores are reported out on the pathology report. So typically you can see a Gleason score, which is anywhere from lowest could be 6 all the way up through 10, but you also need to have the scoring breakdown, which is the number right next to it. So in 3 plus 3, we know that the dominant pattern is 3, and also any other secondary pattern is 3. So this is essentially saying that the patient has a homogeneous Gleason pattern 3 throughout that gland, and therefore they have a total Gleason score of 6. On the other hand, for the next 2 lines, we see that the patient has Gleason score 7. However, one line says 3 plus 4, and the other line says 4 plus 3. And this is where really the distinction comes into play. In the second line where it says 3 plus 4, the patient's dominant pattern, the majority of the pattern is pattern 3, but however, there is a minority pattern of 4 that can be seen. And this suggests a much more higher aggressive disease compared to a pattern 3 plus 3. If we go on to the third line where it says 4 plus 3, this is an even more aggressive pattern where the patient has a majority pattern 4 and a minor component of 3. So even though 3 plus 4 and 4 plus 3 both equal 7, 4 plus 3 actually has the worst outlook, and we could see that on the far right-hand side in the biochemical recurrence-free progression. So all of this gets to be a bit confusing, both for talking within, particularly in talking with patients about their diagnosis. Patients, if they hear that the scale is from 1 to 10 and their lowest possible diagnosis is a 6, they're automatically going to assume that they might have much worse disease than they actually have. So in 2014, Jonathan Epstein and the ISIP group had actually rework the Gleason scoring system to make it a little bit more easier to convey information, and also to simplify the nomenclature. So rather than saying 3 plus 3 or Gleason score 6, they transformed it into these 5 Gleason groups, Gleason grade groups. So you can have grade group 1, which is 3 plus 3, grade group 2, which is 3 plus 4, and so on. And they were revalidated to show that they were predictive of biochemical recurrence-free progression. Now, what's interesting in terms of Gleason scoring and the final prognosis for the patient, the Hopkins group actually took a look at over 14,000 cases spanning over 35 years, where they looked at purely all the grade group 1 cancers, the most indolent disease, and they regraded them on the more stricter 2005 ISIP criteria to look for just patients with pure grade group 1 disease. And what they found is that none of those patients out of over 14,000 cases had a lymph node metastasis or distant metastasis. And so what the authors concluded based on this very large retrospective review is that in order to actually metastasize, Gleason 4 or Gleason 5 pattern needs to be present within the patient's prostate. So knowing this, it would in theory be very simple to differentiate between who has metastatic and lethal disease and who has indolent disease. As long as we know the patient has pattern 4 or pattern 5 disease, they clearly would need surgery, and the rest of the patients can go on to active surveillance. Unfortunately, the only way to know what's in the prostate is to actually take out the prostate, in which case definitive or curative therapy is already done. And we can't necessarily rely on that needle biopsy. This retrospective review of 8,000 cases from Mayo Clinic Rochester shows that in 20% of cases where the patient has 3 plus 3 on the needle biopsy, at surgery, the patient actually had much higher grade disease. And again, in 20% of cases where the patient had 3 plus 4 disease on biopsy, they actually had much lower grade disease. And so we can't reliably use the needle biopsy to help us understand what's truly in the prostate because of the sheer nature of how prostate cancer manifests, which it tends to be multifocal and also heterogeneous in terms of tumor grade. So we know that our current tools have their limitations in terms of being able to risk stratify. So a lot of researchers were looking at actually building new tools to better risk stratify patients in low and intermediate risk prostate cancer. And in terms of building a more effective tool, we needed to reach 3 criteria. We needed something that has that predicts a clinically actionable endpoint. It needs to add value beyond the traditional markers such as tumor volume, Gleason grade, PSA status, and then also it needs to address the inherent heterogeneity of prostate cancer, both in terms of tumor grade, the sheer fact that that it's multifocal in nature, and then also biopsy undersampling. So if we look at the image on the right, if the patient were to have the standard 12-core TRUST biopsy, the transrectal ultrasound biopsy, the patient may not, or the physician may not necessarily see that very small high-grade focus on the far right-hand side, and may only hit with 1 or 2 biopsy needles the low-grade focus on the left-hand side. And without knowing that the high-grade focus existed, this patient could, in theory, be sent to active surveillance, even though they're harboring aggressive disease. So typically, prostate cancer, in terms of outcomes and endpoints, we tend to focus on overall survival and disease-specific survival. However, for low and intermediate risk disease, they're not particularly useful endpoints. Due to the long natural history of prostate cancer, there's actually very low events when it comes to death in this subpopulation of prostate cancer. People have attempted to look at intermediate endpoints, such as metastasis-free survival, and metastasis-free survival has been identified as a robust intermediate endpoint for localized prostate cancer, but those prostate cancers all tend to be high risk. So they are higher grade, higher volume disease that are not classified by the NCCN as being low or favorable intermediate. And again, metastasis, like death, there are too few events but in the low and favorable intermediate groups for those to be useful in terms of clinically risk stratifying these patients. Again, if you look at the PROTECT data, at 10 years, there was only 1% to 1.5% rates of death for active surveillance or surgery. So you're not going to be able to really risk stratify patients based on this endpoint. And again, PROTECT had largely low and intermediate risk patients within their cohort. And for metastatic disease, at most at 10 years, you'll see a 6% rate of metastasis. And I would argue that there's not much to risk stratify here. In theory, if you were to have a tool that risk stratified based on metastasis alone, patients that had a 5 or 6% rate of metastasis would go to active surgery, whereas patients with a 4% or less may go on active surveillance. But clinically speaking, is there much of a difference between a patient with 4% risk of metastasis versus a 5% risk of metastasis? And if you were to ask that patient that, they may not necessarily have a consistent opinion from patient to patient. So because endpoints like overall survival and metastasis-free survival are not necessarily as useful in low and favorable intermediate risk populations, we're going to look at another near-term endpoint, which is adverse pathology. And the researchers from the University of Michigan actually looked at 2,800 cases and attempted to look at various combinations of adverse pathology to determine what was most prognostic. And what they found was definitions 4 and definitions 5 had the best hazard ratio in terms of predicting biochemical recurrence in patients. And on further analysis, definition 5, which is a combination of high-grade disease and non-organ confined disease. So T3A is extracapsular extension, T3B is seminal vesicle evasion. If you have either high-grade disease or non-organ confined disease, you would see the most reclassification of patients into risk groups that had the strongest prognosis for or were most associated with biochemical recurrence. And so again, they found that adverse pathology using the specific definition in definition 5, which is again high-grade disease and non-organ confined disease, was your best bet in terms of identifying patients at higher risk for bad outcomes. And we see the analysis from the University of Michigan researchers being confirmed in the literature itself. If you look at various large cohorts where they look at outcomes for patients, the patients that have adverse pathology at radical prostatectomy tend to have much higher rates of all endpoints. So they have lower progression-free survival times, they have higher rates of biochemical recurrence, metastasis, and prostate cancer-specific mortality. Whereas patients who had low or favorable intermediate risk disease at biopsy and went on to radical prostatectomy, if they had favorable pathology, so low-grade disease, organ-confined disease, they had much lower rates of failure. And so because of this, and because adverse pathology seems to be a much more nearer-term endpoint that can predict longer-term outcomes, new risk stratification tools have been designed to be used to predict this adverse pathology endpoint. So for the rest of the talk, we'll be focusing on MRI, magnetic resonance imaging, as well as genomic testing. And in terms of multiparametric MRI, the point of the testing is really to provide a visual assessment of the disease. So getting a better understanding of the geography of the disease, and there's an associated scoring system that can give you the probability of high-grade disease. Genomic testing, rather than giving you a visual assessment, provides you a molecular assessment of the underlying tumor biology, and genomic tests are designed to be associated with different relevant clinical endpoints, such as adverse pathology, biochemical recurrence, metastasis, and death as well. And they're also designed to be independent of clinical pathologic covariates. So in terms of how multiparametric MRI works, what happens is a patient enters the MRI machine and a magnetic field is turned on. The magnetic field causes all the protons to reorient and align to the field itself. At that point, while the magnetic field stays on, a radio frequency pulse is put out that flips it to be against the magnetic field. This causes a strain on the proton. The pulse is then turned off, at which point energy is released and the proton realigns with the magnetic field. So it's this constant pulsing of putting the proton into a strain position and then releasing it that allows for an image to be captured and then analyzed in the software to render a visualization of what's going on in the prostate. And the energy is released in terms of the intensity, and the nature of that energy is varies depending on the tissue, which is why you can get a differentiation between the cancer tissue and the normal tissue. MRI itself is used in multiple clinical settings. It can be used before the biopsy, and while it's not necessarily diagnostic, it can give physicians a better idea of whether or not the patient's harboring regions of interest that might be holding clinically significant cancers that need to be biopsied. Of course, that's really in the clinical trial setting and not necessarily used in the clinic or routine practice. What we'll be focusing on is using MRI during the pre-primary treatment phase, where the patient is having a biopsy and we want to target specific regions of interest to make sure that we sample the highest grade disease. And also to a lower degree in the surveillance cohort, where the patient is diagnosed and chooses active surveillance and we're monitoring them for further disease progression. In order to standardize MRI assessment, the Pierats system, which was created, which is the prostate imaging reporting and data system. And this was really designed to focus on the likelihood of finding adverse pathology. And their adverse pathology definition is a little bit different. Rather than 4+3 disease that we saw in the Kosminski paper that I mentioned earlier, the Pierats system really looked at 3+4 disease, and also disease that was higher than 0.5 cc's, as well as extraprostatic extension. The scoring system itself is from 1 through 5, the 1 being highly unlikely of finding this sort of clinically significant disease, and 5 being highly likely that the disease is present. Again, MRI itself is not necessarily diagnostic of the disease, but it can point physicians to the right area to actually sample, and also give them a general idea of what they're likely to find. So MRI is made up of 3 separate components. There's the T2 weighted image, which really looks at the fatty tissue and water-based tissues in the body. Diffusion weighted imaging, which looks at the motion of free water within tissue. And then also dynamic contrast enhancement, which is really looking at the vascularity or the leakiness of the blood vessels within the prostate and the tumor. And changes within the normal tissue and cancer tissue can be spotted based on these different qualities of the different images, and radiologists can look between all 3 images to identify the areas that they find to be suspicious and assign a score to those areas. So depending on which zone of the prostate we're looking at, the different imaging components hold different weight. 70 to 80% of all prostate cancers are found in the peripheral zone, and in those cases, the diffusion weighted image, it holds the highest weight, and the dynamic contrast enhancement image is really used to separate out between Pierats 3 and Pierats 4. In the transition zone, where about 20% of prostate cancers are diagnosed, the T2 weighted image is what really drives the Pierats score. And the only difference or the only differentiation that diffusion weighting image offers is between Pierats 3 and Pierats 4. And really the point of this is to really highlight the fact that Pierats scoring is really predicated on one particular image, and it's important to get a high quality image in order to do accurate Pierats scoring. In terms of the NCCN guidelines, MRI can be used for patients when they're considering staying on active surveillance. So you can use MRI to confirm a patient's candidacy for active surveillance. And also in terms of monitoring disease progression, if you see a patient go from a Pierats 3 to potentially a Pierats 5, that's suggestive of higher grade disease. Now, that doesn't necessarily take a patient off of active surveillance by itself. However, it would trigger a physician to likely re-biopsy that patient, especially biopsy that Pierats 5 area to determine if there's higher grade disease within the organ. But the NCCN does highlight that no parameter, including changes to the MRI, are very reliable at detecting a disease progression. And we'll see the data in the next few slides as to why that is. So overall, there's actually many dozens, if not hundreds, of studies looking at MRI and how well they perform at finding high-grade or non-organ confined disease. And the consistent theme from all the data is that MRI targeted biopsies are much better at finding clinically significant disease while missing clinically insignificant disease compared to the 12-core systematic trust biopsy. So again, in general, the MRI targeted biopsy can identify disease that we should worry about, so the 3+4 and above, and specifically miss the 3+3 disease, whereas the 12-core biopsy tends to pick up all these cancers, and especially those 3+3 diseases that you don't necessarily need to worry about in terms of managing the patient's care. MRI is good, but not great at finding all clinically significant disease. While MRI has a high negative predictive value, the positive predictive value actually varies quite significantly, anywhere from 60 to 90%. And because of that variability, there's some false negatives and false positives that happen that we'll see in the next couple of slides. So again, this study that was noted or cited in the NCCN guidelines shows that MRI performs quite well in detecting larger volume disease in tumor that's over 5 millimeters, and also in higher grade disease, specifically in Gleason 4+4 and above. And we notice that the sensitivity actually drops substantially when you're looking at a lower grade disease, so Gleason 7 and below, and also disease that's smaller in terms of volume, so 5 millimeters below. The sensitivity actually drops across all MRI components. All that being said, we still have great level 1B evidence that shows that MRI definitely improves the detection of clinically significant disease. In the PROMISE trial that enrolled about 740 men, 576 of them all underwent an MRI, followed by MRI targeted biopsy, trust biopsy, and also TPM biopsy, which is total prostate mapping. In other words, this is a saturation biopsy that actually takes anywhere from 50 to 90 cores from the prostate. So this technique is not typically used in a routine patient care, but however, it is used in some clinical trials, and it's believed to be as effective, if not better, than radical prostatectomy, simply because in total prostate mapping biopsies, you get to map patients who have very low risk and low risk disease who wouldn't necessarily go to radical prostatectomy. So it removes some of the bias from looking at adverse pathology outcomes in radical prostatectomy. In this particular trial, clinically significant disease was defined as having 4+3 or above, or also having a higher volume of disease in terms of having 6 millimeters or more on any particular core. And in terms of negative predictive value, the MRI actually has an 89% negative predictive value, which means that if a patient has a Pierats 2 or Pierats 3 score, they are likely not to harbor any sort of high-grade disease. Here's the more granular breakdown of the data. So in 576 MRIs, about 27%, 158, were called Pierats 1 or 2. And the vast majority of those, of the 158, 141 cases, they found no cancer or clinically insignificant cancer on saturation biopsy. So essentially, the majority of these Pierats 1 and 2 was correctly called that the patient was not harboring insignificant disease. However, in 10% of the Pierats 1 and 2 cases, there was clinically significant disease that was considered to be missed. On the flip side, of the 576 MRIs, 418 patients had a Pierats 3 or above, and which would suggest that the patient's harboring higher grade disease. However, out of those 418 positive calls, only 213 actually had significant cancer, which means that 205, over half the patients that had a positive quote-unquote call for harboring significant disease, ended up showing no significant disease or no cancer at all. So while MRI does have a high negative predictive value, it actually has a much lower positive predictive value. In this particular study, only about 56%, which is really no better than a coin flip. If we look at the precision trial, in this particular study, we looked at patients who underwent MRI-targeted biopsies versus trust biopsies, and only patients that had Pierats 3 or above actually underwent biopsy. And what we see is that, again, you see this continuing theme where MRI-guided biopsies were better than trust biopsies at finding higher grade disease while ignoring lower grade disease. And again, we see that MRI has much lower rates of calling 3+3 disease, whereas the standard 12 core trust biopsy was actually finding a lot more 3+3 disease than really should be detected. So in terms of applying this data to the clinical setting, it seems reasonable to take all patients who have Pierats 1 or 2 lesions, who also had a 3+3 on their biopsy, to conclude that they are not harboring aggressive disease. And of course, this call would really need to be made, assuming that the Pierats 1 and 2 score was being called up by an experienced radiologist, as we've noted that there's a high learning curve in actually doing Pierat scoring in a way that's consistent to all these clinical trials. If a patient has Pierats 3, 4, or 5, and they have a 3+3 or 3+4 finding on their biopsy, they'll likely need to have additional information before you can actually make a confident treatment decision. In terms of MRI being able to detect non-organ confined disease, we see that the negative predictive value actually varies in terms of how good MRI is. Overall, the negative predictive value is a little less than 70% for MRI. However, if you look at just purely low-risk patients, the negative predictive value actually gets closer to 90%. So in a very select cohort of low-risk patients, MRI tends to be effective at identifying the absence of T3A disease. However, the caveat, again, is that you need a highly experienced radiologist to make the call. If you look at a systematic review by the Cochrane Review of 43 different studies, they created a model that looked at how the frequency of false negatives if patients who used MRI targeted biopsy versus systematic biopsy. I'm not going to go into this slide in any particular detail, but I just wanted to point out that if you looked at patients who used MRI for their targeted biopsy for diagnosis, there was an 8% false negative rate, whereas if you were to use the 12-core systematic biopsy, there was an 11% false negative rate. So again, there is a consistent miss across the different types of biopsies in terms of calling or miscalling the absence of clinically significant disease. So in terms of where we're at with multiparametric MRI, in terms of strengths, the MRI is really good at ruling out insignificant disease because of its high negative predictive value. And it is superior to trust biopsies in terms of finding clinically significant disease, and again, while overlooking insignificant disease. It does have the potential to reduce the number of biopsies needed in certain men. We're not necessarily there yet in terms of using MRI before the first biopsy to decide who should get a biopsy and who doesn't, but I feel like the data is marching in that direction. Now, in terms of limitations, there is a wide variability in PPV and MPV data for MRI's ability to find clinically significant disease. So while, again, MRI tends to be good at ruling out clinically insignificant disease, there is still a wide range in its ability to actually find clinically significant disease. And that's largely due to variability in terms of equipment and operator. And so there's a significant learning curve as well as inter and intra-observer variability. MRI seems to consistently miss at least 10% of clinically significant disease, and arguably Pierats may be using a suboptimal definition of adverse pathology because, again, they based it off of the presence of 3+4 above disease, whereas we've seen in other research that 4+3 and above disease might be the better definition for adverse pathology. So switching over to genomic tests look at the molecular biology of the disease rather than taking a visual approach. So genomic tests typically use tissue that's already been retrieved from the patient, either through the diagnostic biopsy or subsequent surveillance biopsy. A small piece of that tissue is extracted for RNA and analyzed using different methodologies such as RT-PCR or microarray. The expression levels for a preset bank of genes is measured and normalized and then run through a clinically validated algorithm to produce a result that then a physician can use to guide treatment selection. So there's several different commercially available tests. The most popular are the following three: the Polaris test, which is a 46-gene assay, the Decipher test, which is a 22-gene assay, and the Oncotype DX GPS test, which is a 17-gene assay. For the purposes of this talk, we'll only be talking about the last two. Again, we're looking at comparing genomic tests and MRI. And since MRI is looking at adverse pathology, we'll also be discussing Decipher and Oncotype DX, which also have adverse pathology as their endpoints. It should be noted, just like MRIs, including the NCCN Guidelines, molecular testing is also listed as being something that should be considered for both low-risk patients as well as favorable risk patients in the most recent NCCN Guidelines. First, we'll take a look at the Decipher test. This is a 22-gene panel that was developed by GenomeDx, and originally it was designed to look at the prediction of early metastasis. And in terms of the assay development, they used RP samples or radical prostatectomy samples where they specifically microdissected the highest grade focus and did their gene discovery using the highest grade of cancer available on the radical prostatectomy. And they have had multiple validation studies which show that their score is associated with predicting the risk of high grade disease at radical prostatectomy, as well as metastasis at 5 years after radical prostatectomy and 10 years death at 10 years after radical prostatectomy as well. Their score is from 0 to 1, with low risk being from 0 to 0.45 and high risk from 0.6 to 1. And that will give you a score, or the scores are typically associated with a percent risk of the following outcomes: high-grade disease, metastasis, and 10-year survival. So for the purposes of this talk, I won't necessarily go into all the different validation studies for each of the genomic tests. However, they've all been clinically validated for their various clinical endpoints that they're looking at. For this particular talk, we'll be looking at the performance of these genomic test results in the context of MRI-guided biopsy. In this particular pilot study, we see that And the authors looked at the transcriptome-wide analysis of MRI-targeted biopsies and matched them to the radical prostatectomy in about 27 patients. What they found was that as long as you tested on the highest grade needle biopsy available, you get an 83% concordance in decipher score between the sample and the radical prostatectomy. There was a much lower concordance if you were to use a lower grade biopsy when you compare it to the decipher score generated from the radical prostatectomy, and this is likely due to the fact that their original development and validation work really focused on using the highest grade tumor from the radical prostatectomy. In the same study, if we look at how the decipher results looked across different Pierats score, we actually see a clustering of results. So all the low decipher scores clustered around Pierats 1 and 2, and all the high decipher scores clustered around Pierats 5. Now, the initial look of this data, of the small pilot study, would suggest that there's no real utility in using one test over the other, or rather, there's no real utility in using both tests combined. You can either use one test or the other because they seem to both predict each other. However, if you look at a larger study of 100 patients, you actually see a much larger variation in decipher score results across different Pierats and Gleason scores. So in patients with Pierats of 1, 2, or 3, and 3+3 disease or Gleason grade 1, you can actually see both low risk and high risk scores. And again, we see that in Gleason grades 2, Pierats 1, 2, 3, and 4 and 5 as well. So this would suggest that there is actual utility in using the decipher test in addition to the MRI guided biopsy to get a better understanding of the patient's potential for aggressive disease. In terms of the genomic prostate score, the GPS test, this was a 17-gene panel assay developed by Genomic Health, and it was designed from the start to look at adverse pathology at radical prostatectomy. So again, high-grade disease, non-organ confined disease. And in terms of gene selection, for the development of the study, they actually looked at both the highest pattern as well as the dominant pattern. And the point of doing this sort of gene discovery was to mitigate the likelihood that tumor heterogeneity will affect the score itself. So they were looking at genes that were expressed both in the highest pattern disease as well as the dominant pattern disease that had equal weight in terms of prognosis regardless of which pattern you hit. And subsequent data has shown that the GPS score varies very little depending on which tissue you test, which would suggest that the heterogeneity may not necessarily be as large of an issue for this particular test. In terms of the real utility of the test, if you look at NCCN risk groupings, the NCCN very low risk group buckets all patients as having an 84% likelihood of having favorable pathology at radical prostatectomy. So for all comers, if you're listed as very low risk, you would just assume to have an 84% chance of having good pathology at radical prostatectomy. Conversely, if you're NCCN intermediate risk, you had a flip of a coin chance in terms of harboring good or bad pathology. What's useful in terms of risk stratification is applying a genomic marker to these buckets or classifications. And you can actually see the actual underlying spectrum of risk these individual patients might have. So a patient can have intermediate risk disease. However, their likelihood of favorable pathology, say if you had a GPS of a 5, could be as high as 75% chance of having good pathology, no aggressive disease, or you can have as low as 30% chance, which means that there's a very high risk of actually harboring high-risk disease. And again, the interesting thing is here is the actual overlap between the different risk groups, which would suggest that despite these patients having different volumes of disease and different Gleason scores of disease, they could biologically actually function quite similarly to each other. And because of this, there's a belief that we can actually find those patients that actually have biologically indolent disease as opposed to phenotypically indolent disease. In terms of the test results, the results go from 0 to 100, and they allow for a patient to be reclassified from their clinical pathologic NCCN risk group to a combination GPS NCCN risk group. So they can either stay consistent with their ClinPath risk group, or they can be quote unquote upgraded or downgraded to another risk group. And this helps physicians determine whether the patient actually has harbouring worse disease than they actually suggest. On the first page, the very last number is the percent risk of adverse pathology. For this particular patient, they have a 15% risk of adverse pathology. And on the second page of the report, you can see where that patient falls in terms of their biologic score compared to the rest of patients that also have NCCN low-risk disease in their validation studies. So this patient has a particularly low-risk type of disease since they appear to be on the tail end of the distribution. The individual components of risk of adverse pathology are listed on the second page as well. This patient has a 9% risk of high-grade disease and a 10% risk of non-organ confined disease. And again, on the first page, they have that 15% chance of having one or the other. In terms of the Oncotype DX GPS test performance in the MRI targeted biopsy setting, a cohort from UCSF of 100 patients were looked at. And what they wanted to see in this study was whether or not there was an association between MRI findings, so the Pierats score, and the GPS result. And the authors originally hypothesized that the Pierats score would be strongly correlated with the GPS result, so that the higher the Pierats score, the higher the GPS result. Interestingly enough, in this study, rather than finding a strong correlation, they actually found a weak correlation between Pierats score and GPS result. This wide distribution of GPS results within each Pierats score would suggest that there's actually a wide range of biology contained within these separate GPS scores, and that would suggest that the GPS result is actually providing information that's independent to the Pierats score. And again, the result is validated to predict adverse pathology and oncologic events independent of other pathology assessments, and this seems to be consistent with other findings. So again, we can see that the GPS result does have a wide range regardless of Pierats score and as well as Gleason score. And so there's no clustering effect that's necessarily seen. Although these are small numbers, this would probably need to be confirmed on subsequent larger studies. So again, in terms of the conclusion for this study, there was only a weak correlation found between MRI, Pierats scoring, and GPS testing, which would suggest that both systems represent independent predictors of outcome, and the wide overlapping distribution of GPS value would suggest that there's value in doing testing in addition to MRI targeted biopsy. Now, again, while we see a range of biology, we need to see data on whether or not the genomic testing is actually useful in predicting adverse pathology above and beyond what MRI targeted biopsies can do. And so in this study of 134 patients from UCLA, the authors were looking at just that, whether or not the GPS test can predict adverse pathology in the setting of using MRI targeted fusion biopsy to theoretically target the highest grade disease. So can GPS add more information in terms of predicting bad disease over what MRI is supposed to do, which is predict bad disease? And so again, like the previous study, we see a range of GPS scores across each Pierats score, so there's no clustering. So this again would suggest that there's an independent amount of information that's being provided by GPS. And if you look at the modeling that was done, the area under the curve was highest when you actually combined Gleason score, GPS, and highest Pierats score, and that AUC was 0.79. Interestingly enough, if you take away the Pierats score and just look at Gleason score and GPS, the area under the curve is also 0.79. Whereas if you look at Gleason score and highest Pierats score by itself, it's 0.69. So this data would suggest that GPS certainly adds information to Gleason score and Pierats score, but Pierats score doesn't necessarily add further information than just simply having Gleason score and GPS result. So again, this shows that the genomic testing really is complementary to MRI targeted biopsies. In terms of surveillance, we actually see that the UCSF had recently published a study looking at how patients perform in the active surveillance setting. So this particularly looks at GPS scores, Pierats scores, and whether or not men are upgraded on subsequent biopsy. So all these men had 3+3 disease that were put on active surveillance and were subsequently biopsied, and the authors were looking for whether or not there was a biopsy upgrade from 3+3 to higher grade disease. And what they found is that if you look at the 25th percentile, which is a GPS of 16, the majority of patients did not have a biopsy upgrade. So their Gleason score stayed as a 3+3 from their initial diagnosis to their subsequent confirmatory biopsy. However, if you looked at GPS of 29 and above, those patients did have a trend towards biopsying at a much higher, upgrading at a much higher rate. So if you had a GPS of 29 or above, those patients had a much higher likelihood of finding 3+4 or worse disease on confirmatory biopsy. And we found that this effect of the GPS test being more predictive than Pierats and multivariable analysis. So what we found was that the GPS test, if you had a score of 29 or above, there was a 2 in 3 chance of a patient failing active surveillance within 3 years. And so this data would suggest that a patient who has a high enough GPS result, because they would have a high likelihood of failing active surveillance because they would have a biopsy upgrade, they may want to discuss doing immediate therapy rather than wait the 3 years. Whereas if you have a low GPS of 16 or lower within 3 years, there's a 75% chance of not finding any higher grade disease. And so patients and physicians can be more comfortable with the fact that they'll likely be able to stay on active surveillance for at least 3 years. And these GPS cutoffs actually outperform the Pierats score 1 through 4 versus Pierats 5. And the authors conclude, again, that it may be reasonable to use GPS in shared decision-making to determine who benefits from active surveillance, and that patients who have a GPS of higher than 29 are more likely than not to fail active surveillance in 3 years. So in review, in terms of strengths, multigene signatures have shown underlying biology cannot be fully assessed by phenotypic markers. So this includes ClinPath features as well as imaging. The added strength of genomic testing is also that it's centralized and it's objective in terms of its measurement with minimal variability. And you can see those in the analytic validation studies for each of the assays. There's also a much lower threshold for adoption and implementation, as there's no capital expenditure in terms of getting an MRI, the equipment, and also training the staff as well. And there's also ever-growing clinical validation and utility data coming out for genomic tests. In terms of limitations, there is limited data for how useful these tests are in MRI targeted biopsy setting. However, more data is to come in the next few years on that. And there's no long-term outcomes in active surveillance populations. So while that previous UCSF data that I had just shown was the first of its kind in an active surveillance population, it was only for a couple of years, and we need longer-term outcomes to see how well genomic tests can help in risk stratifying these patients. And then lastly, there's rather little health economic data in terms of standalone versus combined use of MRI and genomics to see what's most cost effective. In terms of combining both genomic testing and MRI in low and intermediate risk patients, for practices that are already using MRI targeted biopsies, MRI really should be sufficient in and by itself if a patient has a low Pierats score, so specifically a Pierats 1 and 2, and they have a 3+3 on their biopsy. Based on all the data that we just looked at, as well as a significant amount of data in the literature, these patients are not likely harboring higher grade disease. Now, if a patient has a 3+3 on biopsy and they have a Pierats 3, 4, or 5, they would benefit from genomic testing because, again, the positive predictive value for a Pierats 3, 4, or 5 is not that great, and it's not entirely known whether or not the patient actually had the highest grade actually sampled. And the same issue also exists for 3+4 biopsies. Again, there's a controversy on whether or not 3+4 patients all have clinically significant disease, and there's a subset of these 3+4 patients that do go on active surveillance. So simply finding 3+4 on biopsy does not necessarily give you enough information to make a treatment decision between immediate therapy and active surveillance. And for practices who are only using the 12-core systematic biopsy, it becomes highly context dependent on which methodology to use. I would offer that genomic tests typically have a lot of patient assistance programs to reduce financial toxicity for patients, and they also present with minimal logistical challenges for the patient. They would have already had the biopsy, and the biopsy would be available at the pathology office. So there's no other additional visits or interaction that would need to take place to get a genomic test done for those patients. So in terms of future directions, we still need larger studies to clarify what the full range of genomic test results are for each Pierats group or Pierats scoring group. And then we'd also like to have confirmatory studies showing that GPS results, as well as other genomic test results, are still informative in the MRI targeted biopsy context, and specifically in improving area under the curves results. There'd also be a need for health economic analysis to determine where the cost and benefit is for either using one modality or the other alone or in combination. And then lastly, whether or not MRI and genomic tests can be used to reduce or increase surveillance intensity. So there is a large push towards reducing the number of unnecessary biopsies, and MRI data as well as genomic testing data could potentially help us tailor or modulate the intensity of surveillance for patients so that we can minimize biopsies and the attendant side effects. So thank you very much for attending this talk. I appreciate your time, and if you have any questions, feel free to contact me. Thank you.